Welcome everyone to today's webinar discussion. I'm Morgan Hafner with Becker's Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the presentation by typing them into the Q&A box you see on your screen. We look forward to hearing your questions. This session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access that recording. At this time, it's my pleasure to kick things off by introducing our four presenters. First is Leah Klinke, Assistant Vice President of Hospital Revenue Cycle at WVU Medicine. Next is Ted Severson, Vice President of Revenue Cycle at Monument Health. Then we have Deborah Lau, Head of Revenue Cycle at The Ohio State University Wexner Medical Center. And lastly, Patrick Wall, Interim Vice President of Revenue Cycle at St. Joseph's Candler. At this time, I'm pleased to turn the floor over to Nick Fricano, who is the President and CEO of HealthViews, to begin today's presentation.
Yeah, thank you, Morgan. Good afternoon, everyone, and thanks for joining the Becker's webinar, The Road to Recovery. I'm Nick Fricano, CEO of HealthViews, and we have a really informative and I think well-timed presentation for you all today. I'm very excited to get started and most excited about our great group of panelists who have joined us today. Before our panelists introduce themselves and their organizations, it goes without saying that 2020 has been a year unlike any of us have ever experienced, not only in our careers, but in our personal lives. From the outset, the rumors of a pandemic, how deadly it is, fear of the unknown, lockdowns, school closings, et cetera, and then to see these events unfold. And at the forefront, healthcare. Hospitals and health systems were and still are the vanguard of our country's planning and response to COVID-19. Today, we're focusing on the engine behind the scenes, the integral part of healthcare that keeps hospitals' doors open and operating, the revenue cycle. We will be asking specific questions of our panelists, and then we'll open up for a question and answer session, time permitting at the end. I've had the great honor of working with each of the panelists, and we're about to hear how they've survived and even thrived during this pandemic. So now, without further ado, our panelists, Leah, Deborah, Patrick, and Ted. Folks, please introduce yourself and your organizations, perhaps starting with Leah.
Hello, I'm Leah Klinke. I'm the Assistant Vice President of Hospital Revenue Cycle for WVU Medicine. We are a 12-hospital health system based in Morgantown, West Virginia. We are on Epic, and we are in a period of rapid growth where we've been adding about 2 to 3 hospitals a year to our system and converting those hospitals to Epic to become part of our enterprise hospital revenue cycle. I'm over patient access, utilization review, hospital billing, and customer service.
Thank you, Leah. Deb?
Hi, I'm Deborah Lowe. I work at the Ohio State University Wexner Medical Center, which is an academic medical center, state-operated, located in Columbus, Ohio. We are a 7-hospital system, including a PPS-exempt NCI-designated comprehensive cancer center. We have about 1,700 faculty members, 30,000 staff, and $4 billion in annual net revenue, with 65,000 admissions and 2 million outpatient visits. Our revenue cycle is not completely centralized, and we are on Epic.
Thank you, Deb. Patrick?
Thanks, Nick. I'm Patrick Wall. I'm the Interim Vice President of Revenue Cycle for St. Joseph's Candler Health System, which is a multi-specialty health system serving a 33-county area throughout southeast Georgia and southern South Carolina. We're anchored by 2 hospitals in the Savannah area with combined inpatient beds, about 714. But we have been in a period of rapid growth as well, and we have recently opened several large outpatient campuses throughout the 33-county region.
Thank you, Patrick. Ted?
Thanks, Nick. Hello, everybody. My name is Ted Severson, the Vice President of Revenue Cycle at Monument Health. Monument is headquartered in Rapid City, South Dakota. That is on the eastern side of the beautiful Black Hills. We are a community-based healthcare system. Our mission is to make a difference every day. The system offers care in about 33 medical specialties and serves 20 communities across western South Dakota and eastern Wyoming. We've got 4,500 physicians and caregivers, and we're comprised of 5 hospitals, 8 specialty and surgical centers, and more than 40 medical clinics and healthcare service centers. We are a member of the Mayo Clinic Care Network, and we are an Epic shop. We've been that for a few years now, and had a couple nice years of growth that we've experienced. Thank you.
Yeah, thanks, Ted, and thank all of you. The objectives we'll be discussing this afternoon really revolve around different areas within the revenue cycle impacted by the pandemic, specifically related to 3 main areas. 1, vendor trends and the effects the pandemic induced both regionally and nationally. Secondly, lessons from frontline revenue cycle leaders. And then lastly, really proactive, growth-minded vendor management strategies into the future. As the moderator for today's call, I'll just take a quick moment to introduce HealthViews. We've been fortunate to work with and partner with each of today's panelist organizations, and it's truly an honor. It has been an honor to do so. So a little bit in terms of HealthViews, very briefly before we jump in. As most of you are revenues, or all of you are revenue cycle leaders on today's webinar, you guys all understand that healthcare revenue cycle has only grown increasingly complex. As that's happened, so many hospitals and health systems across the country have leveraged vendors to support their revenue cycle operation to manage that complexity. And there's oftentimes a gap between expected results from these partnerships and actual. That bridge is HealthViews to really bridge the gap between expected and actual results. So we support organizations in building and operating a revenue cycle vendor management office, a revenue cycle vendor management unit, to create transparency and trust between the hospital and vendor partnership to create mutual benefit. The pandemic certainly has created a financial crisis for hospitals. Revenue cycle teams really had to adapt quickly, redeploying staff and relying on vendors to fill the gaps. HealthViews has been there to support our hospitals' rapidly changing needs and gaps during this unprecedented time. So before we jump into the discussion, I wanted to give a bit of a state of the union, state of the industry, which I think we've all certainly experienced. But just to summarize, certainly the impact of COVID-19 on hospitals financially has been catastrophic. I cannot think of another time in my career when so many organizations across the country had to lay off or furlough employees, pivot to a remote workspace environment, recast budgets, and to make the tough decisions as to what was considered essential versus not essential to any organization's survivability. For hospitals, the dramatic drop in patient volumes was felt throughout the industry. There are really 3 main areas that attributed to massive, reductions in these volumes, which are outlined on this slide. With consumer anxiety, 18% of consumers said they are likely to avoid the emergency department despite showing signs of a heart attack or appendicitis. And 34% of consumers said that they are likely to avoid the ED despite, a cut that may require stitches. People avoiding the ED for conditions this severe is a snapshot into the overall avoidance of visiting the ED for potential, serious conditions, not to mention less severe cases. Regarding economic instability, there is decreased demand following losses of job and insurance coverage. 41% of survey respondents from our research had health insurance coverage through a job that was either lost or furloughed. And among those who previously had coverage, 21% are now uninsured. as we look at throughput and efficiency, the last column here, 76% of health systems closed, divested, or downsized ambulatory buildings and offices. 2/3 rationalize excess inpatient capacity, and nearly 80% of all health systems had a layoff or furlough staff. Taken individually, any of these factors would have had a large impact on healthcare organizations, but the reality is all of these and more have happened simultaneously. We've all experienced this. We've all seen this over the last 8 or 9 months. Certainly been a concerning and a challenging situation, unprecedented. But you know, at this point, we really would like to turn to some of our discussion points. You know, featuring our panel, who are really leading, you know, very high-performing revenue cycle operations, to better learn, you know, what they've done leading up to COVID, what they're doing during COVID, and as we begin to come out of it, which we certainly will eventually, you know, what their plan and vision is. So, jumping to our questions, our first questions. Deb Lowe, I think we're going to start with you. How have you kept your team engaged? I know you, Megan, and your team moved fast to respond and get your team home safely. Please share how you did that and how have you, you know, how you've kept your team engaged these last 8 or 9 months.
Thanks, Nick. Well, we scrambled just like everybody else on this call to get folks home. We were lucky. We had some folks working from home partially before the time hit, but not our scheduling department and not our switchboard. So it was a scramble to get everybody home. We set up with tools that we were able to. We actually ended up sending a lot of folks home with desktops instead of laptops because we just couldn't get those. We sent folks out to Target and other stores to get headsets so that we were able to function and did that pretty quickly. We were lucky that almost all of our staff were on some form of productivity already that we were able to continue to monitor to make sure that they were able to function in their new role, and we had workforce management enrolled for scheduling so that we could make sure folks were using their scheduled time as appropriate. We kept engaged through virtual town halls. I sent a monthly missive to everybody showing a vulnerability across the organization as we were dealing with all of the new stressors, having children in the home while we were trying to accomplish work. And that was the main way we kept engaged. In the last 60 days, we've actually started an engagement committee because we found some folks were doing some really cool things with their staff, but we weren't sharing them with each other. And we had a couple of fails. We also wanted to make sure folks might not want to try something that didn't work well in another group. So we have a committee together that across all units of the revenue cycle are sharing their engagement plans at home with everybody else as we move through this time frame and try to keep everybody as engaged as possible as things change. We stood up a COVID call center and a COVID swab station immediately and had to pull folks out of a lot of jobs in order to man that. So we've shown our flexibility and our willingness to cross cover in areas that we hadn't done before.
Yeah, thank you, Deb. I know you guys were really at the forefront. Leah, you know, just to pick on you for a minute, and certainly Patrick and Ted, I want to give you guys the opportunity to respond to this point as well. You know, I know for some organizations there's a bit of, you know, pandemic, you know, fatigue. You know, folks working remotely. How have you guys addressed that, and you know, team accountability and you know, really establishing sort of, you know, different goals and refocusing your team over the last several months?
So we also were, we already had a home-based model for some of our people. We had about 33% of our staff working from home and transitioned to now about 75% of our staff working from home. And actually it was something that we tried to encourage people to do prior to the pandemic, but didn't get a lot of engagement from some of our people who hadn't worked from home before. But we've actually found that our staff, a lot of them prefer to work from home and actually want to continue to work from home even after the pandemic, which has actually been a pretty positive finding for us. We were already operating as kind of a remote centralized business office with people sitting kind of throughout the state at different business offices, but not necessarily reporting to someone they were sitting next to. And so home base doesn't really make a big change from a leadership perspective. And so actually working from home like eliminates some of the, unproductive activities that go on when you don't have your supervisor sitting right in front of you. So we have, had trouble keeping in touch with our staff, I think, during this time. I think that's probably one of the drawbacks. We did actually have our PFS week, which we planned entirely remotely this year, and planned some really fun activities. It was interesting that the folks that were in the office were the ones that were feeling the most left out, I think, the people who were unable to work from home, because we have moved so much to focusing on our home-based staff, so that's something we also have to work on. It's just a big shift for everyone.
Yeah, thank you, Leah. Patrick, I know St. Joseph Candler had a bit of a different approach. What was the approach you guys took?
Yeah, our executive leadership team made the decision early on to continue working on campus, and fortunately, the Savannah area was not initially heavily impacted when most areas of the country were spiking. Our local mayor and county commissioners did a great job in handling the pandemic early on. Now, we did take extra precautions. We implemented PPE requirements, installed additional sanitizing stations. We increased our EVS team to sanitize throughout the day in the business office and other areas of the revenue cycle. But we did send our high-risk staff home. So if there were other health concerns to take into consideration, then the majority of those people did work from home, and many are continuing to work from home. We did, however, completely prepare for a transition to the home environment. We have to do that for hurricane season. So we have a plan that we can implement at the flip of a switch to send our revenue cycle home, to include our call centers, our scheduling, centralized scheduling, and our customer service. So, we had a one team, one goal campaign that we launched to keep everyone motivated, and had several different activities that took place throughout the pandemic related to that initiative. We did cross-train our coworkers into other areas, especially when volumes were down. So we made a commitment, and fortunately we were able to do that, but we made a commitment early on to our coworkers that we would continue to pay them for their scheduled hours. And so, of course, we did have a lot of cross-training going on. For instance, when the scheduling phone lines weren't ringing, we had to have something for those schedulers to do. But we did take a little bit of a different approach. But it worked out well for us, and we did not have any issues.
Okay. Thank you, Patrick. Ted, anything to add before we move on to the next topic?
I would just add, right leaders at the right time. We benefited quite a bit. We have a chief medical information officer, which for a smaller system can tend to be a luxury. So Dr. Stephanie Lahr is our CIO, and she really helped prioritize and work with the senior executive and executive teams to come up with a work from home potential and strategy that cascaded in terms of readiness. And we brought that through the entire system with the priority of trying to get as many people home as possible. Of course, we did peak much later than most others across the nation. In fact, I would say we are peaking now. This is our first COVID peak. And other solutions that we've utilized, again, working with people like plant and plant ops, is making sure to maximize floor space. I'm in an older education building where we've got a couple floors that tend to be pretty empty, and we've set up workstations with some safe spacing. But getting the right technology tools prioritized to allow people to work from home, which we struck out on almost immediately, was our priority. And then we've also seen a little bit of a boon from the recruiting standpoint, given that we're a rural health organization. Recruiting, of course, tends to be a challenge for us because not everybody can make the drive, especially in the wide open spaces here in South Dakota. But having technology tools in place for telephone and remote access have afforded us the privilege of being able to look into outlying areas and have greater potential to recruit from people that might not want to make a 2-hour drive into a centralized office. So it's really modified our ability to recruit and retain. Of course, most caregivers do want to work remotely and feel safe, but we're also seeing kind of an interest for some people in coming back to the office as well. So with floor space available as well as remote technology, we're able to kind of cater to either or depending on what the current surge condition is. Thanks, Nick.
Yeah, thank you, Ted. And folks listening in, we are going to be taking questions at the end. But as you have questions now, just as we have a discussion, please feel free to go to the Q&A section of the webinar, type up your question, and we'll make sure we'll do our best to answer it during this session, if not afterwards. So let's move on. Really, an extension of our internal team, our vendors, and in particular our outsourcers, that are extensions of our people in our team. How do you see your vendor strategy, changing over time? And Ted, maybe you can continue here. I know you guys have done an awful lot here over the last couple years. What's changed, and how do you see your vendor strategy changing, if at all, in the future?
Yeah, certainly. Thanks, Nick. We have done quite a bit of work in the past year and a half, going on 2 years, in terms of planning and enhancing our vendor relationships. It's a strategic priority in revenue cycle, and I would even say within the organization, to make sure that we're properly aligned. I touched on that subject with my prior response. We do have a challenge here as a rural health organization, recruiting, retaining, just because of where we're located. It's essential that we maintain strong vendor relationships. So we did bring a vendor management partner in-house. It's been a wildly successful initiative for us. Really looking at how did that evolve during the COVID times. We do have an early out and AR follow-up partner, and because of a furlough situation that we navigated, we didn't have to engage in furloughs for 2 to 3 months there in select areas. One of the areas that was impacted was revenue cycle. We did have to kind of scale back our level of engagement to try to keep more work in-house to help reduce cost. And so we were able to successfully do that. We got a great partner that we worked with that was very accommodating and understanding, and I think that's a key to any partnership. Our vendor relationship is very strong thanks to our vendor management partner. And in that process, we did have to hit the pause button on looking at our initiatives for additional outsourcing and partnerships. Again, our vendor relationship manager understood that. We were very transparent for those people that were courting us in particular areas of technology, as well as our partnership with our vendor manager. So they were understanding, understood the numbers behind it. Fortunately, knock on wood, we haven't been impacted as severely as some of the areas of the nation in terms of revenue. I know a lot of people out there are struggling. Michigan, Ohio, there's a lot of states, a lot of particular areas with services that are struggling right now. We're blessed we're not one of those at this point. We are navigating big numbers. But because of that, it really has kind of stymied a lot of our new vendor initiatives. With that said, we do plan actively and partner with our vendor management partner for aggressively seeking those partnerships in the future. They'll include things like AI and other technology solutions, and hopefully successfully cross a finish line maybe when we get a final solution for this virus. So thanks, Nick.
Thank you. Fingers crossed there. Patrick, has St. Joseph Candler brought any areas back in house that were previously outsourced to help avoid furloughs, or any new areas outsourced due to a lack of internal resources? What have you guys experienced?
I wouldn't say that the pandemic has changed our vendor strategy. We had several strategies in motion before the pandemic, including insourcing of our early out collections unit, which has been extremely successful even in the height of the pandemic. But outside of that, we've been on a bit of a revenue cycle transformation over the last 2 years, and I think that it's really put us in a good position as a health system. The transition has primarily focused on process and technology, and really looking at how do we implement artificial intelligence and other automation platforms. And I think what that allowed us to do in the height of the pandemic was take those resources and focus them on other activities. For instance, when a lot of elective cases began to cancel, we had scheduling capacity to be able to look at the schedule for the next day and move appointments up for those non-elective cases so we could keep the next day's schedule as full as possible from a scheduling efficiency perspective. We had implemented a dialer for our scheduling area that had allowed us to have those efficiencies and be able to focus on some of those things. We had automated our pre-cert process through artificial intelligence, and so that allowed us to take our pre-certification folks and really focus them in on medical necessity and medical necessity denials for those cases that don't require pre-cert. But I don't think that our vendor strategy has really changed. We had a lot of things already in motion, but it really allowed us and set us up to be as successful as we could be throughout the pandemic. And once we made the decision as an organization and felt more comfortable to begin scheduling elective procedures more widespread, through some of that technology that we had been implementing over the last 2 years. For instance, we took all of our cancellations for COVID and put them on scheduling dialers to try to backfill those appointments and cases as quickly as possible. So I don't think that it's really changed our strategy, but like I said, I think that the vendor strategy that we have had over the last couple of years has really set us up to be as successful as we could have been in the pandemic.
Yeah, Patrick, thank you. That's great. So AI, automation, technology in particular, things that were newer, at least in the last 2 years, sounds like, scheduling dialer, pre-cert in particular, among other things that you had prior to that?
Yep.
Thank you.
What was the end of that question?
No, you had called out, AI automation around pre-cert, scheduling dialer. Were those sort of two of the new initiatives in the last 2 years prior to what was already in place, or were there other sort of new tech in AI that you brought in?
Our new automation strategies really were around automating the pre-cert process, incorporating dialer technology for pre-registration and for scheduling. And like I said, it really allowed us to shift a lot of resources to look at things like medical necessity reviews for cases that didn't require pre-certification, or making sure that we were able to schedule every order that was sent within 12 hours is our time frame right now. We implemented that same dialer technology in our new early out unit, which has really been successful. We were able to insourced that unit, and we increased our self-pay collections by roughly 40% in the midst of the pandemic. We really didn't incur any additional cost because of the technology that we had already brought on board for the pre-services areas. We implemented some new artificial intelligence for claim statusing. We had a technology for many years, but went a different route, which allowed us to incorporate claim statusing into our host EMR, which is Meditech, and really just gain a lot of efficiency in the claim status process.
Yeah, Patrick, thanks so much. Deb, what have you guys experienced? Anything that you brought in house? Anything that you're looking to outsource that was previously, done in house because of a lack of resources? What have you guys experienced?
So we've been on a path for the last 4 years to really insource. Prior finance administration was so mindful of the FTEs, they didn't allow us to reduce expenses, but now that we're been on a push to reduce expenses, they've seen the wisdom of bringing stuff in-house. So we brought underpayment in-house. We're in the process of using machine learning to identify at the time the claim drops what claim we think will be underpaid so that we can be proactive. We've installed some automation to check RTE on all of our Medicaid patients that could change plans every month to make sure that the auth is still effective at month end as the new month starts, and then we're only looking at the exceptions. We've automated MBI check to get our academic GME payments. We've automated the COVID Optum process to make that a much less heavy lift for our 300,000 plus COVID tests we've done so far. So our strategy had been continued in place to insource, which has kept our cost to collect down as we've had minor growth in our FTEs. But the pandemic really didn't change that strategy. We did take a pause for a couple of months as we were distracted doing other things, but we're back on track with building some of our automation in-house, as well as we've outsourced some of our automation.
Thank you, Deb. And Leah, any reprioritization of vendor projects or anything different that WVU experienced?
I don't think I would say that we've changed focus. I think I could ditto what some of the other speakers were saying with the insourcing automations we've been working on a claim statusing automation project throughout the pandemic. I would say our focus towards insourcing has been a focus of ours, but has allowed us to continue to focus on it. As we take on new facilities and incorporate them into our centralized billing office, we acquire the staff of those existing facilities, and a lot of these are small facilities, and we're able to do things with Epic more efficiently than they were before. So we're constantly looking to make sure that everybody's busy and that there's work to that there's work to spread around with all the new staff on our team, and so that's kind of been the focus of our insourcing, is making sure that that we're utilizing the staff that we have to benefit the work of the revenue cycle. We actually refocused our staff during the lull in work there when volumes were down. We had done a complete restructure of our business office in 2019, and our results really had slipped. And our aging was high and other things, and we were able to refocus our staff during that slowdown on aged accounts to accelerate cash, and ultimately got ourselves into a much better place from a revenue cycle results perspective through the pandemic. So that's the silver lining.
Yeah. Thank you, Leah, and thank you, folks. And really, just to summarize, it sounds like while as the pandemic started, it certainly slowed things down as each of the organizations are sort of managing that change. But that the direction is largely unchanged, right? The vision that was brought, that you guys had going into the pandemic, really into 2020, has continued, and that, it sounds like insourcing has been part of that. Some pivoting has been part of that. Looking at new vendors in some cases, in particular, and AI and automation has been critical to that. Thank you, folks. Moving on to the next question, and this is sort of an interesting one, right? It's sort of looking back, and if we could do a do-over, or if we could do it again, knowing what we know now, what would we have done differently? So, what would we have done differently, if we knew the pandemic was coming? So we're in February. I know there were, if we were back in February 2020, what would we have done differently, or even if we had more lead time? What would we have done differently? And it's sort of an interesting question, and perhaps Leah, you can start on this one. You've done a lot over the years to stay nimble and to lead your revenue cycle organization at WVU Medicine well before COVID. What would you have done differently if you had a do-over?
Yeah, it's interesting. I had given this a lot of thought, and I kept thinking, is there anything I would have done differently? I think that probably one of the big things would be to make sure that we had all the hardware technology that we ended up having to try to scramble to acquire. But I would say for the most part, we had a lot of this in place. As I indicated before, we did a whole restructure of our billing office in 2019. Taking all of our individual hospital billing offices and reorganizing them as a centralized billing office module, but it was entirely remote. So our staff were sitting kind of all over the place and not sitting in a kind of a physical pod with their teams. And that really actually, not knowing about the pandemic coming, it actually did prepare us kind of for a quick pivot to a virtual environment. And, West Virginia is challenging in some respects because some of our rural hospitals, there's not a lot of internet connectivity for these folks at their homes. And I was actually pretty happy that we were able to get 75% of our staff home-based, considering some of those connectivity limitations. But we did have trouble getting things like headsets and webcams and other things that make a virtual environment a little bit easier for people to work with. But we did already have technology like Microsoft Link, or Skype for Business it's called, which allows instant messaging and screen sharing. And we already had a VPN set up for a lot of our folks. We already were accessing Epic through Citrix. So there were a lot of things that were already in place that made the shift actually relatively seamless. So I thought about it, and I thought we wouldn't have changed that much going into it. I think we were able to shift pretty seamlessly.
Yeah, thank you, Leah. Ted, how about you? I know there are some similarities in Rapid City versus Morgantown and in sort of the rural parts of West Virginia and South Dakota. What would you have done differently if you had a do-over?
Yeah, thanks, Nick. It really would have focused similarly on making sure that the technology was available for the teams to work remotely going into it. We do have kind of an added bonus here in Western South Dakota. The Black Hills, we don't have internet connectivity and speed sometimes that can accommodate for telehealth or even remote work. So that was definitely one of the challenges that we had in prioritizing remote work for staff, who has the technology, who has the tools, because some people actually can't work remotely because their satellite internet is blocked by a mountain, for instance, or trees. Real life scenarios there, and that impacts patients as well. So really that remote work potential and capability, making sure that we had the right hardware available. We did have a hardware checkout option for our caregivers, because of course a lot of them, because of limited access, some of them might have had an old laptop that they'd bring to a coffee shop when they wanted to get internet or not. So definitely some cultural and technology challenges working in some of the rural areas. Now that's not the rule, it was the exception, but it definitely would have made a difference ahead of time to have a bit more of that ability going into the pandemic. Thanks, Nick.
Yeah, thank you, Ted. And then Deb, I know you guys were quick as was Leah and Ted's group in particular in terms of going remote. Do you see folks coming back? Those folks that are remote, today, do you see them coming back to a CBO or back to the facility? And if so, when? And then maybe just if you'd want to add anything, like what would you have done differently, if you had a do over here?
Well, let me answer the last question first, and then talk about permanence of work at home. I wish we had enforced, encouraged, demanded that our physicians do more telehealth, because we went from 10% telehealth to 90% telehealth practically overnight, and we had to go out and get a second and third vendor because nobody could handle the volume. So it made scheduling and working in the provider offices very complicated for the first couple of months until things settled down and we ended up on a single platform. But we were allowing the providers to make the decision to go to telehealth. And, of course, not all payers were real happy about telehealth prior to the pandemic. So I wish we had done that. I wish I'd bought stock in headsets and webcams. There certainly was a demand for those. And we just finally this month got all of our staff outfitted with webcams that went home with desktops. But as to the permanence of work from home, we've had lots of conversations with our staff. We are, because everybody obviously wants the space to know, can we reallocate the space for something else? I got almost 1,000 seats across the organization in various spots, and everybody wants space at some point in time. But I think the jury is still out. I think that we're all missing that face-to-face conversation. While our organization has been more collaborative than it's ever been during this stressful time, I think everyone is really missing that face-to-face conversation. So my direct reports have been coming back in 2 or 3 days a week just so that we can connect in a large conference room with masks on and feel like we're connected, even though we have a weekly virtual meeting. So my jury is still out on, do we end up bringing 25% of the staff back, 35% of the staff back in some form 2 days a week, or are they going to be at home 100% forever? I don't have my crystal ball working yet.
Yeah. Thanks, Deb, and certainly, none of us do there, and I think that then there's a question of do folks want to come back, as this is sort of remote working for many has become a new norm, and I don't know if there's any trophy to be the leader on this as well, right? So thank you. Patrick, anything you'd add? Anything, if you had a do-over, anything you'd do differently?
The one thing that I could think of would just be to focus more on cross-training. As we talked about earlier, when volume started to decline and you didn't have a lot of work for scheduling or pre-cert or some of those areas, and we started to pull them into other areas where we did have work, I think focusing on cross-training early on would have been helpful. We already had the plan to do remote work if we needed to do that. We do that every year for hurricane season, and we review that every year in preparation for that. So that would not have been a challenge for us, but I do think that cross-training would be something that we would focus on more.
Thank you, Patrick. And maybe keep us going on the next one, Patrick, as well. I know, as we were talking about discussion point 2, and even the last one in 3, it was like the vision that each of your organizations, each of you had going into the pandemic, that you stayed true to that. Initiatives that were underway, you continue to pursue. It may have slowed down a little bit, but have priorities changed? While the overall vision may have relatively stayed the same, have initiatives or priorities changed, the ordering of initiatives? And Patrick, I know, you guys have a whiteboard or perhaps many of them with your top initiatives, and as you erase one, you add 2 or 3. Has that list changed? Has the ordering of that list changed over the last several months?
I don't think so. As you mentioned, we do have a daily huddle with all of our leadership team, and even with our frontline team members with their leadership team across the revenue cycle every day. And so amongst our various revenue cycle huddle boards, there are hundreds of different initiatives and opportunities that we are looking to employ. At a high level, right now we've got about 38 different strategic initiatives that we're looking at in the revenue cycle over the next 12 to 18 months. And I don't think that those have necessarily changed. One that we have looked to focus on a little more is a strategy around a virtual registration. And I think that COVID has really brought that to light. One of the things that we were piloting at one of our campuses prior to COVID was really a virtual waiting room. And how do we allow a patient to check in once they arrive at the facility from their phone so that we know that they're here? And we started looking at that prior to the pandemic, but I think, with COVID and people not wanting to wait in a waiting room, it is how do we accelerate that and make that more widespread and enterprise-wide? And how do we even make it bigger than that? So how do we do more than just create a virtual waiting room? How do we create an entire virtual registration process? I think the nature of what we're dealing with today is that patients don't really have the time to talk to us. If you think about it, normally they'll talk to us at the point of scheduling, and then they'll talk to us when we pre-register them, and then they'll come talk to us, at the point of registration, and maybe some other times there in between if there's a problem with their authorization. But patients don't have the time. They are busy with work. Now they're busy with homeschool or virtual school. And so what we're looking at is how do we create that from the point of scheduling and to the point that they arrive for the procedure, how do we make that virtual? So if you think about Amazon, and you can go on your Amazon app and you can order something and it arrives at your doorstep in 2 days and you don't have to talk to anybody to get it there, how do we make it so that a patient can put in a request for scheduling for a specific procedure, and on the back end, they tell us their appointment day and time preferences. On the back end, we look for their order, we match their order, we put them in a scheduling slot, we send them a notification of their date and time, we push a notification to pre-register remotely, we do the verification on the back end, we push their estimate to them so that they can pay it, and then days later, when they arrive for their appointment, they check in virtually. The registrar sends them their documents electronically to sign, and then they get notified when it's time for them to be pulled back for their procedure. That's something that we've been talking about for probably 6 months to a year now, and I think that it's been on the horizon, but it's time that we really put that at the forefront, and I think that's something that we will be focusing heavily on over the next 6 months, because I think that the reality is that we have the technology to do it. It's just a matter of unplugging it and plugging it back in. So that's the one thing that we'll be focusing on heavily over the next few months.
Yeah, Patrick, thank you. And just looking, folks, we have about 700 attendees on, and I'm looking at some of the questions, and we have over a dozen questions in the queue. What I'd like to do is perhaps Ted, Deb, Leah, is sort of blend this question with the last question, so we can chip away at least some of the questions that have come in. Sort of blending, has the priority changed versus sort of what's next as you think forward, beyond 2020 and into 2021. What does your plan look like over the next year plus? And perhaps starting with Deb here.
Well, we have always had a net revenue goal every year of increasing net revenue, not just collecting the net revenue that is out there, but how do we have an impact? And this year it got augmented because of the hole that was created in the spring. So our major initiative this year is to increase our net revenue across the organization by $17 million by many things, improving CDI, reducing denials, and through all of the automations I talked about earlier. As we continue to grow, I'm not going to be allowed to have FTEs. As we continue through the pandemic, we'll probably go back into hiring freezes. So how do we do the work that needs to be done without having people here? So we continue to build our internal bots within our own shop. We've got citizen developers, and then we have collaborated with an external vendor to build the ones that actually will end up being AI versus just a true bot. So our major strategies this year are to do more with less, to stop doing things that aren't value added, do all those lean things that we've always talked about doing. Now's the pressure. And for the first time in a long time, we're actually talking about centralizing all of the revenue cycle functions within one area.
Yeah, thank you, Deb. Ted, how about you? How about Monument Health? What's next?
Yeah, thanks, Nick. We're really focused on, and it should come as no surprise to most listeners, transparency right now for a few different reasons. One of them maybe because of a federal mandate, but other reasons is, how well transparency bundles itself with the subject of access. And when I mean access, I don't mean the access departments. I mean the concept of access. There's a saying that revenue cycle is actually all of us, and it truly is. We do have departments within revenue cycle, but there are very few areas of hospital clinic operations that do not affect the revenue cycle. And what we've seen from the pandemic and what we hear back from patients, it's not just about transparency, it's not just about billing questions, it's about access points for tests, for care, for availability. So that is a growing, concern for the community, for the consumer base, but it's also a focus for our organization going forward. What technologies can help support that? Where do we engage in lean engineering to help structure and create better access? Whether it's through physician scheduling availability, through authorizations and technology. There are a lot of different avenues to look down, but transparency and access really remains at the forefront, and I think the pandemic has really just helped exacerbate that for us, the opportunity. Thanks, Nick.
Thank you, Ted. And maybe one or two more follow-up questions. Maybe Leah, to you. What's next for WVU Medicine? And do you feel the organization, is better prepared to handle another pandemic? Hopefully, we don't need to, but how would you assess the organization's readiness going forward?
So, as I indicated before, we're in a period of rapid growth over the last few years, and we really have moved towards our standardized platform of Epic for all of our facilities, which I think has really helped us both in integrating a care for our patients, coordinating care across sites, but it's also helped us definitely on the revenue cycle side to be very efficient and streamlined among our team. And we're able to create specialized teams that do specific work, and the technology platform being the same allows us to kind of streamline the process and spread it across sites, providing the same service for all sites, regardless of their size or their location. So that's just going to continue for us, and we're actually planning the acquisition of, or I should say consolidation of 2 other facilities into our system that are larger than some of the ones we've done recently. So that's on the horizon for us. Also spreading outside of West Virginia into other states. which is also going to be new for us from a revenue cycle perspective. Some of the projects that we're working on is continue work through AI and automation, hopefully through doing some auth automation some of the other leaders have talked about, also working towards more pre-service financial clearance for our patients, both on the insurance side and the self-pay side. So the patient's portion, as well as getting the authorizations from the insurance for care, and kind of melding that with the work that we've been doing related to estimates related to the price transparency regulation that's coming very soon. So those are some of the bigger projects, but that just mixes in with our typical 2 to 3 Epic conversions a year, and all the other projects that kind of just come to us throughout the year. So never a dull moment.
No doubt. Leah, thank you, and folks, thank you. We have about 5 minutes left for questions, and we're probably going to hit against a hard stop here. I think we have 14 or 15 questions in the queue, so we're gonna jump on those here in just a minute. I just want to thank our panel today, Leah, Ted, Deb, Patrick. Thank you each for taking the time to prepare for today's event and sharing your insights and your perspective. I also want to thank everyone for attending. I will say, just as a close, HealthFuse is offering a courtesy benchmark and opportunity analysis associated with overall revenue cycle vendor strategy. And if anyone's interested in that, certainly reach out to us, let us know. But with the remaining couple minutes, Morgan, I want to hand things over to you. I know we have several questions in the queue, and we'll try to answer those as efficiently as we can.
Absolutely. Thank you, Nick. So if you do have any other questions, please do submit them at this time. Hopefully we can respond to as many as possible. So I'll start off with a question about stimulus funds. An audience member is wondering, how are various organizations adjusting their financial reporting to reflect stimulus funds, blended with standard inflow of payer revenue, et cetera? If anyone has some insight that they can share on that, that would be really helpful.
So I think the best way, since we can't see each other, in video or not in person, which is a little bit easier to have an exchange, I'm going to sort of start at the top of the list and with Leah. And Leah, if you have anything to add, please do. If not, maybe just pass, and then Deborah, Patrick, Ted. I think that'll be the order. And folks, if there are specific questions, you can direct it to a particular panelist if you'd like to as well. But I think otherwise that'll be the order. Pass or go, I think, is the MO.
Leah, I'll pass on that one.
Okay.
Yeah, I'll pass on that one because that's more of our finance department that handles that.
And I'll give a little input. I know that we are reflecting it in the financial statements, but I can't tell you if it's above or below the line.
Patrick, Ted, anything to add on that one? Okay. Morgan?
All right.
Next question.
Next question is around metrics. Someone is wondering, what metrics are revenue cycle leaders most focused on today? And has their focus on metrics changed since COVID? So we'll go through that same list. Leah, Deb, Patrick, then Ted, comment or pass.
This is Leah. So we were having kind of an aging problem prior to COVID, so we really have focused on keeping our aged AR greater than 90 days down. Obviously, we focus on our net days in AR as well. Those have been the main ones that we've been focused on. And then on top of that, trying to keep our initial denial rate and denial write-offs down. Basically, we're trying to liquidate as much as we can.
This is Deb. We are really focused on the percent of cash collected as of net revenue. That's our key metric, since we can't control the payers, how long they're holding the money right now, as well as our DNB.
And Patrick, or Ted, do you have anything to add?
Yeah, I don't think I have too much to add. We're looking at AR days aging, denial rates, recovery rates, DNFB, cash collections, and those types of things. And I don't think that that's changed due to COVID.
Yeah, for us, Monument Health, we stay really dialed in on clean claims, and then denials, total denials, and primary insurance denials.
Excellent. Thank you all for that insight. And I'll ask one more question today. This might pertain to those who have outsourced, but what goes into an organization's decision to outsource their revenue cycle operations rather than look for technology or process improvement? So we'll start with Leah, go through Deb, Patrick, and Ted. If you could give some insight, it'd be great.
So this is Leah. For us, and as I've indicated before, we've acquired staff from all different sites as we're acquiring facilities, and we've really focused on insourcing versus outsourcing, mainly because we already have the FTEs and we want to make sure everybody's busy as opposed to paying an outsourced expense. So our focus really is if we can do it and do it well, we will insource.
And this is Deb. Our biggest decision maker is, do we have the talent and bandwidth internally to be able to handle the project and be able to do it? And then return on investment, can we do it less expensively than outsourcing? Plus, I have some control issues, so that has some play.
This is Patrick. We primarily look at ROI and capacity. So is it more effective for us to outsource it or insource it, and then do we actually have the capacity to implement any kind of technology, staffing, and all of that sort of stuff at that particular time?
And this is Ted with Monument. I would agree with that. Return on investment is our primary. I would say our intangible is how it complements our culture, especially within our community, as well as our internal corporate culture. Making sure that values align and that people are taking the right steps on purpose and consistently. That goes into vendor evaluation and management for us and makes a big difference in who we pair up with.
A really great question and such valuable insight. So I want to thank Leah, Ted, Deborah, Patrick, and Nick for their excellent presentation in our speed round Q&A. And I also want to thank HealthViews for sponsoring today's webinar. So to all of our attendees, please enjoy the rest of your day, and we really look forward to having you join us for future presentations.
Folks, thank you all.
Thank you.